Hello, everyone, and welcome to this learning session. My name is Mahsa, and I'm a pharmacy resident at Vancouver General Hospital. I'm going to be talking about post-lung transplant immunosuppression. My objectives for today are to be familiar with most common immunosuppressive medications used in lung transplantation, for us to be able to describe advantages and disadvantages of medications within each class of immunosuppressive agents, and be familiar with the common side effects and common drug interactions associated with immunosuppressive medications. The first lung transplant was done in 1963, and it's an established therapy for treatment of end-stage lung disease. There's been many advances in modern lung transplantation, including improvement of techniques, immunosuppressive therapy, and treatment of infectious diseases, which have really prolonged the survival of these transplant recipients. This is the lung transplantation process that each recipient goes through. They're first referred to the transplant team for a pre-transplant assessment. This is mostly done in an outpatient clinic setting rather than in a hospital. And it involves many healthcare professionals working together: nurses, physicians, surgeons, pharmacists, psychologists, social worker, and dietitian. And once the patient is approved for a transplant, they get activated and they go in a wait list for transplant. And once it's their turn and they actually receive their transplant, they would usually be in the hospital for 10 to 30 days, being taken care of by all these wonderful healthcare professionals again. And then post-transplant, they come back frequently for transplant outpatient clinic appointments to get assessed by another multidisciplinary team who will get to know them very well. There are a couple issues post-transplantation. One is immunosuppression, which is done to prevent antibody production and T-cell mediated response against foreign organ and organ rejection, so basically the body attacking itself. And also the toxicities of these medications that are used for immunosuppression. And then on the other hand, there's complications of immunosuppression because we can't fight off infections anymore and we end up getting infections. And also cancer is another complication associated with long-term immunosuppression. In order to decrease the risk of infections, we have learned to prophylax people with antimicrobials. So you would see a lot of these patients on Septra and valganciclovir and all that. There's a fine balance between the two that must be kept in order to not push patients into rejection, and on the other hand, not cause them to have any infection or a cancer or other complications. Since the first transplant has been done, there's been so many advances, like I mentioned, in the medications especially. And you can see how many new medications have come to the market since around 1990s. And you can see that the 1-year survival has dramatically increased, and the rejection in the first year has significantly decreased ever since the first transplant was done. So this is an overview of immunosuppression. It has two parts. One is the prevention of rejection, which is the most important part, and the other is treatment of rejection. For prevention, we have induction therapy, which is maximum the first 5 days post-transplant, and then after that we have maintenance therapy, which goes on for life. Induction therapy, we would use high-dose IV steroids and antibodies. And for maintenance therapy, we would give patients typically one of the calcineurin inhibitors, one of the antimetabolites, the mTOR inhibitor, sirolimus. That is only given to patients if they have had refractory rejection or malignancy, and it is contraindicated in lung transplant for the first 3 months just because it interferes with the healing of the anastomosis. So you have to be careful about that. And typically we would give them prednisone. For treatment of rejection, we have antibodies that we can use and high-dose IV steroids. This is the part that we're going to be focusing on today: prevention of rejection. The first group I want to talk about is drugs that are used for induction therapy. And the first drug is basiliximab. How it works is by suppressing activated T immune cells, and the dose is 20 milligram IV. The first dose is given post-op day 0 in the ICU, and the next dose is given 4 days later, usually in the ICU or sometimes in T12 step down. In terms of monitoring points, it's important to monitor for infusion reactions such as hypotension or urticaria, and adverse drug reactions include headaches, flushing, and nausea. The flushing is interesting because you would hear patients say they feel hot and cold all of a sudden. But usually it's temporary and it will go away once the infusion is stopped. The next drug is RATG or thymoglobulin. It looks like this. How it works is by killing all kinds of immune cells. So the T cells, the B cells. It's a very potent drug, and the dose is here for you to see for 3 days. The monitoring points is one of them is anaphylaxis, which is very rare, but it can happen. And the adverse drug reactions, fever, chills, neutropenia, thrombocytopenia, which is not surprising because of the potency of this medication. Now let's talk about maintenance therapy. The first group is calcineurin inhibitors, and I want to talk about tacrolimus first. So I'm sure you're familiar with tacrolimus. How it works is by suppressing T cell activation, and the starting dose is usually 0.05 to 0.3 milligram per kilogram per day, PO or through NG tube, divided BID every 12 hours. And it's titrated to a target trough of 6 to 12. And this target trough can change depending on how long it's been since the transplant. For monitoring precautions, I would be careful about antacids in food because they can reduce the absorption of tacrolimus. So the dose needs to be given consistently every day. And usually that's why we hold NG tube feeds before and after tacrolimus dose is given. In terms of adverse drug reactions, you can see headaches, tremor, which is pretty visible, blurred vision, GI upset, increased potassium, increased serum creatinine, and the daily levels are usually done with the morning blood work. It's important to be aware of the different PO formulations. Not every tacrolimus is the same, and you can see that Advograph has once daily dosing, whereas Prograph is twice daily, and they're not interchangeable with Envarsus either. So you can ask your friendly pharmacist for more information, but make sure that you're not interchanging one for the other. Cyclosporin comes in different formulations, the capsules and the injection form. It works by suppressing T cell activation, and the dosing, it starts with 5 milligram per kilogram per day, PO or NG tube, divided BID, and it is titrated to target trough of 150 to 450. In terms of monitoring and precautions for adverse drug reactions, I would watch out for headache, confusion, gum hyperplasia is common, hypertension, and there are daily levels done with the morning blood work for this medication as well. Now let's go to antimetabolites. The first one in this group is mycophenolate. It comes in different formulations, mycophenolate mofetil or Celcept, and mycophenolate sodium or Myfortic. These two are not interchangeable because the dosing is different, but they both turn into mycophenolic acid, which is the active ingredient in the body. There's also the IV formulation and an oral suspension. How it works is by stopping B and T cell growth. The dosing is 1 to 1.5 gram PO or IV every 12 hours. And in terms of monitoring, there is an interaction with antacids in food, similar to tacrolimus. And the adverse drug reactions, nausea is a big one, diarrhea is really, really common, vomiting, and cytopenias. Azathioprine or Imuran comes in tablet formulation and IV. How it works is by stopping B and T cell growth. And the dose is usually 2 milligram per kilogram PO once daily. In terms of monitoring, I would monitor for cytopenias. It is very common, so anemia, leukopenia, thrombocytopenia, and nausea, cholestasis, and pancreatitis can also occur. Mechanistic target of rapamycin inhibitors. The most common one that we use is sirolimus or Rapamune, and it comes in an oral solution as well as a pill formulation. How it works is by stopping T cell growth and preventing antibody production as well. The dosing is usually you start with 2 milligram PO once daily, and then you titrate it to a target trough of 3 to 13 nanograms per milliliter. These troughs that you're seeing, they all can change depending on how long it's been since transplant. In terms of monitoring and precautions, it does interact with food because food reduces its absorption. Adverse drug reactions, you can see hypertension, increased cholesterol and triglycerides is very, very common, and cytopenias. And there is daily levels with the morning blood work that are done for this medication as well. Steroids, there is the pills or prednisone that is commonly used here, and the IV formulation or methylprednisolone. How they work is by suppressing inflammation and the immune system. They have multiple mechanisms of action, and the dosing is not that simple. So once they arrive in the ICU, you would start them on the methylprednisolone, which, as you remember, is part of the induction plan originally, and then you give 125 milligram IV at 8, 16, and 24 hours post reperfusion. And then post-op day 1, you start them on a prednisone taper, dose of 1 milligram per kilogram per day. And the dosing tapering regimen is either by 5 days or 3 days, and that differs based on the patient's weight. In terms of monitoring and precautions, it can cause a lot of anxiety, insomnia, mood changes, and psychosis. So you will hear a lot of patients say they have hallucinations, they're seeing things, hearing things, and glaucoma, hypertension, hyperglycemia, hyperlipidemia can happen. Peptic ulcers, nausea, stomach upset is also common. Osteoporosis with longer term use and weakness are also side effects. So really, they're the devil's tic tacs. This picture sums it up perfectly. So let's talk really briefly about common side effects and their management. For basiliximab, we said that it can have infusion reactions, so a rash suddenly appears and it's really itchy, or a patient's blood pressure drops, they have tachycardia or bronchospasm. You can stop or slow down the infusion and then contact the pharmacist or physician. For RATG, if they do end up having infusion reactions, we can actually prevent that from happening by premedicating with Tylenol, steroids, or antihistamine for 30 minutes to an hour before the infusion. Tacrolimus and cyclosporin, if you have any concerns regarding a patient's sudden onset headache, confusion, tremor that is disturbing, or blurred vision, GI upset, hypertension, any increasing potassium or serum creatinine, you can always contact the pharmacist or physician. If they get gum hyperplasia with the cyclosporin, you can try by ensuring that they're following proper oral hygiene and then go from there. Often it can improve by just doing that. Mycophenolate and azathioprine, if they get diarrhea or neutropenia, these side effects often improve with dose reduction. In fact, a lot of the mycophenolate and azathioprine side effects. So you can contact the pharmacist or physician for that purpose. Sirolimus, you can see a lot of triglyceride elevation, like I mentioned, and for these, sometimes medical treatment, for example, with a statin may be required. So please contact the pharmacist or physician for that purpose. Prednisone and methylprednisolone for the steroids, they can increase glucose, like I mentioned, and so initiation of a insulin sliding scale may be necessary. Feel free to contact the pharmacist or physician. And then, like I mentioned, you hear a lot of patients say they have hallucinations, or they can get stomach upset. So if these get persistent and disturbing, you can always contact the physician. So now we have successfully wrapped up an overview of prevention of rejection, and the medications that you see in red are the common ones that we usually use in patients post-transplant here at VGH. And here are my references in case you want to look into these medications a little bit more. Thank you so much for listening and watching my presentation. If you have any questions, you can always email Dr. Robert Wright, our lung transplant pharmacist, at robert.wright@vch.ca.